And this topic is dealing with the lymphoid diseases. Previously, we have discussed the myeloid diseases, and now we are concerning to the lymphoid diseases. Now, when we talk about the disorders of the lymphoid system or the lymphatic system, we can talk about non-neoplastic disorders and neoplastic disorders. Very commonly, we can face with the lymphadenopathy when you are going to sense that your lymphatic node, especially the superficial lymphatic nodes, are enlarged. Sometimes they are very sensitive, tender, especially when you do have a viral infection. In the neck area, you can have lymphadenopathy. That's the general symptoms. Lymphadenitis. Sometimes you can feel, especially if you hurt your skin and you do have staphylococcal infection, that at a very thin red line is going up. That meaning that the lymphatic vessels are infected and they do have infections. So that's called the lymphadenitis. Lymphedema, when the vessels are closed or they do have an accumulation of lymphatic fluid, and this is why it's causing lymphedema. Lymphocytosis. Mostly viral infection is going to increase the lymphocytes. But the viral infection can decrease the lymphocytes, so it can cause lymphopenia as well. Meaning that only separately the lymphoid cell number is altered, increased or decreased. We do have another special case that we are going to deal with today, and that's the infectious mononucleosis, when we do have a viral infection that is going to infect the B lymphocyte and going to cause this pathological condition. But they are still not neoplastic disorders. That's not a deadly disorders. However, if somebody has an immunodeficiency, especially the cellular immune system is altered, for example, we do have a problem with the T lymphocytes, that infectious mononucleosis can be deadly diseases. The neoplastic disease, when we're talking about the monoclonal diseases or the carcinoma of the bone marrow or the hemopoietic system, or the lymphoid system, the lymphomas that usually concentrated the pathologic conditions in the lymphoid system, the lymphatic nodes, for example. That can be Hodgkin and non-Hodgkin lymphomas. Of course, lymphomas can invade into the bloodstream as well, not only stays inside the lymphatic node. You learn these about in pathology a lot. For example, the Hodgkin lymphomas, when we do have a special type of cells inside this lymphatic node, the Steinberg-Reed cells, and there's Hodgkin, and the non-Hodgkin something else that again is originating from lymphatic tissues, and this non-Hodgkin lymphomas has a very huge percentage, about 62.4%. But we are not dealing with these lymphomas here under this course. However, we are going to discuss the leukemias, the lymphoid leukemias. We shall talk about the acute lymphoid leukemias and the chronic lymphoid leukemias. And in the next seminar, we are going to deal with the multiple myeloma when we do have the plasma cell disorders that mostly manifested as. So today we are going to talk about infectious mononucleosis, acute and chronic lymphoid leukemias. These be the topic for this session. Now let's start with infectious mononucleosis when we do have a problem with the B lymphocyte. This is not a non-neoplastic disorders, that's only a viral infection. Now, these disorders, you already heard about it, I think, and a lot of you already infected or already, went through these diseases. This called is the Epstein-Barr infectious mononucleosis or Pfeiffer disease, or the famous name is kissing disease, because this disease is transmitted by saliva, usually by kissing. So you do have an enjoyment as well, and after you are suffering several weeks pain and fever. Now, this is a lymphoproliferative disorder that affecting the B lymphocytes. This stays in the lymphoid tissue and mainly caused by Epstein-Barr virus. This is a herpetiform virus. However, there are some other rare conditions when the cytomegalovirus causes these diseases. The virus is attacking the B cells because on the surface of the B cells we do have this EBV receptor, the CD21 marker, that's a receptor site. And this is how these cells can be accepted. And due to this infection, these B lymphocytes altered, and that's B atypical, usually losing the functions as well. Now, about virology, you will learn more detailed form in microbiology, but this is a DNA virus, it's a linear DNA virus. This belonging to the herpetiform virus type 4, and that has a capsid and glycoprotein envelope. They do have subtypes. We do have 2 subtypes. We do have the type A, that is very common one, especially in the Western countries, and in the type B, that usually causes a less virulent infection. Usually a silent infection is caused by this other type. However, you have to note, and already heard about it, this virus is already connected with some other neoplastic disorder, such as, for example, Burkitt lymphomas, Hodgkin lymphomas, B-cell lymphomas, and some nasopharyngeal carcinoma as well. So this virus does have some etiologic role in the development of neoplasia as well. Now, let's start and talk about infectious mononucleosis. As I mentioned, that this virus is transmitted by saliva. The highest incidence rate is between 15 to 19 years. Usually everybody gets by this time. The incubation period is not so far. It can be about 30 days or 50 days. However, this virus can persist in the oropharynx for 1.5 years. So relatively very long time you can carry, and you can infect some other young one as well. Now, the virus is going to be replicated inside the B lymphocytes in the peripheral blood, or in the liver or spleen, and of course the lymphoreticular system. The disease is a mild disease. Usually is a self-limiting disease that doesn't last longer than average about 4 to 6 weeks. And as you see here, the adultic has about 90% of the antibody against this virus, so already being affected. Sometimes, however, the kids get seroconverted without having any kind of sign, so that's a good in this situation. So if we are going to measure, let's see, the EB virus antibody in this group, almost, well, you are a young one, but older than 19, but at least 80% of you already had this viral infection without having any kind of clinical sign. Now, however, if you be infected with this virus, that's an awful situation. The patient who has this viral infection has very high fever. They do have lymphadenopathy. They do have a painful lymphatic node, very severe pharyngitis, so sore throat, about 90% of the cases. Hepatomegaly, so the liver and the spleen, it's involved, about 60 or 50%. Some people have some maculopapular rash, some exanthemas, and eyelid edema in some very few portion, about 15%. In a mild form, let's say the first start about 3 to 5 days, and a more severe form lasts much longer one. However, the lethargy that usually influencing your mood, that lasts for months. So that can carry for a while. Now, how do we make the diagnosis? Very simple one. Basically, if the patient presented with very high fever and a large, for example, pharyngeal nodes, lymphatic nodes, and you make a cell count analysis, they are counting the lymphocyte count, and that's be very high. It can be around 10 to 20 giga per liter, so it has a lymphocytosis. Plus, if you make a peripheral smear, you will see some atypical cells. Now, these cells, however, they are not B cells. They are T cells. Because what will happen? The infected B cells is going to be recognized by the cellular immune system, and the T cells activated, looks like blastic transformation occurs, and they are going to eliminate the infected B cells. This is why I said, if somebody has a T cell function problem, the disease can be deadly. All right? Now, and another very typical test, That's the Paul-Bunner reaction, when these kind of B cells producing a lot of IgM. And these IgM can cross-react with the sheep red blood cells, and that can be shown this way. This is a Paul-Bunner reaction, or directly can be detected the EB virus or antigen, this serological test as well. This is how we are going to diagnose. Now some picture, pharyngitis, very severe sore throat that the patient is suffering of. This is not a bacterial infection, that's a viral infection. As you see, there is almost obliterated completely the pharynx. And these maculopapular rashes can cover the whole body of the patient. In some cases, not every case. Now this is how a peripheral picture looks like. We do have these light nucleated cells. As you see here, they are bigger one. They are not small lymphocytes, they are bigger one. And they are active, very highly active. This is why the nucleus is very light and very homogeneous, the chromatin that we do have. Looks like it's an acute leukemia. However, this is not a leukemia. This is only an infection, a viral infection, and these are the T lymphocytes, or this called Dani cells, or Dani type of cells, or Pfeiffer cells. This is how they call it. But if you remember this atypical cells, is more than enough to remember. Let's shift to the let's shift to the neoplastic disorders. The neoplastic disorders, usually, as we discussed in the previous seminar, this is results from a mutation in the single lymphoid progenitor cells at one or several discrete stages of development. That's a very important one. This mutation that usually happening in this neoplastic disorder influences more gene, not only one gene. There's a multi-step mutation process is going to cause leukemias. Now, in our case, we do have, let's see, the early stage, the progenitor stage, or the early, let's see, pre-beta cells or pro-beta cells, and after the cells is going to be proliferate, and that is going to form monoclonal increase of these blast cells. These cells can be B cells or T cells. In both cases can happen. Now, as you see here, the epidemiology of the acute lymphoid leukemias, they do have two peaks. The one peak occurs in young one, age 2 to 5. And the second one usually increased by age, but we do have another peak around the age of 50. These are the two peaks. In children, relatively, is very common one. So the most common type of acute leukemia in children is lymphoid leukemia. This is possibly due to the lymphoid dominance in children, because the thymus is enlarged, there's much more lymphocyte we do have in the children comparing to the adult one. And when the thymus is regressed, the granulocytes or the myocytes is going to take over the function of the lymphocytes. The male is more affected than female. And as you see here, in children, about 85% of the cases can be treated, can be cured. That's very high percentage. So if you look at the incidence rate of acute leukemia, in adult one is much more common one, about 10th in the children. But in the children, mostly lymphoid leukemias is going to develop and not the myeloid leukemia. If a myeloid leukemia develops in children, that's a very bad prognosis. Now, another thing that you can see here, in lymphoid leukemia, we can have genetic abnormalities or chromosome abnormalities, and we can have Philadelphia chromosome here as well. Not only in CML, but in acute lymphoid leukemia can be Philadelphia chromosome positive. However, this is only a prognostic sign. This is not an etiological factor. This is a prognostic sign, and sorry to say, but it's a very bad prognostic sign if somebody does have this Philadelphia chromosome positivity in acute lymphoid leukemia. Now, as we mentioned that acute leukemia, and including the lymphoid leukemia, usually they do have an acquired genetic changes in the chromosome. This can be influenced by the number of the chromosome. This is called the polyploidy, for example, or change in the structure, translocations, for example, can be inversion, deletion, point mutation, amplification. So a chromosome or a genome is altered and with a multiple step processing. Now let's see the clinical presentation of this acute lymphoid leukemia. There are some specific symptoms or specific signs that usually is due to the accumulation of the lymphoid cells and the altered cellular response, such as fatigue, decreased energy. That is due to anemia. When we do have an accumulation of these abnormal lymphoid cells, for example, the bone marrow, the normal healthy cells, they do have this contact inhibition and they are going to decrease the proliferation. This is why the number of the erythropoiesis is going to decrease, or the thrombopoietic system is altered as well. So the platelet count is going to decrease. This is why the patient should have some petechia, bleeding disorders. Not only these two, but the white blood cells or the granuloid cell lines or the monocytic cell line are affected as well. And this is why infection is a very common one, and that's a general sign, the fever. And some organs are affected as well, such as the joint, for example, so extremity pain occurs, or organ infiltration in lymphoid leukemia, a very common one. I shall finish. For example, lymphadenopathy is a very common one. So the lymphatic nodes almost involved all the time, and usually symmetric or a single lymphatic node enlargement can be seen. Hepatosplenomegaly, testis is involved in lymphoid leukemias. So the testis is infiltrated and enlarged, or they can invade into the central nervous system directly. So the cerebrospinal fluid, through the fluid, there are some lymphoblast cells can be. And in the thymus, for example, is enlarging and infiltrated with the gland. Yes?
Sorry, I missed. Why is there anemia?
Because anemia is going to develop due to the bone marrow suppression. Now, why the bone marrow, the hematopoiesis in the bone marrow is suppressed? If you think about that, we do have a normally we do have a normal system, a normal cells. These cells, they do have a very, let's say, precisely regulated proliferation rate and capability. Okay, so when they do have an enough number, this contact inhibition is going to shut down the all proliferation processes. However, if you do have an abnormal clone that relatively is missing this regulatory step, what will happen? They are going to proliferate. However, you are going to obey to the rule, not to proliferate if we are crowded. And they are sensing, let's see, how crowded this, let's see, bone marrow is, and this is why they are shutting down. And they are going to let's see, proliferate or overhang the bone marrow, and then other cells, the number is going to decrease. Sometimes, if we do have, for example, at the beginning of this acute leukemia, these blast cells only persist or only proliferate in the bone marrow. And what will be the consequence? In the consequence in the periphery, the patient will sense that somehow red blood cell number decreased, the white blood cell count decreased, platelet decreased. There is no blast yet in the periphery. This is due to suppression. And when the blast is being so high or crowded in the bone marrow, they are getting out easily to the periphery because the markers, the peripheral markers, receptors, they are not going to encode in the fine structure, extracellular matrix of the bone marrow, and they are going to enter into the bloodstream. So what we will have in a bloodstream, especially in acute leukemia, we do have the abnormal clone, the blast cells, and a few that is a normally healthy maturated cells. Nothing between these two. So this is called hiatus leukemicus. We do have a gap, the maturation gap. We do have the matured one that is usually is going to originate it from the normal cell line. Why? In another case, we do have a blast cells that is a clonal abnormal cells persist in the periphery. These two clones, nothing at all. All right? Hiatus leukemicus, or gap in the maturation. So hiatus means a gap. All right? Now, the laboratory abnormalities usually is measuring what we already discussed here. So they're measuring anemia when the hemoglobin content or the hematocrit content or red blood cell content is less. White blood cell count can be high or can be low, as I mentioned. Platelet usually is decreased. LDH and uric acid. Now, LDH and uric acid, serum LDH and uric acid level usually is higher one. That's partially due to the increased turnover of the cells, so the increased catabolic rate, plus hemolysis or altered other system, for example, the liver or red blood cells, that can give you increased LDH activity. And uric acid, that's the purine metabolism is going to be increased. This is why the uric acid level mostly increase in any kind of acute leukemias. Chest X-ray evaluation, usually we are checking for the enlarged of the thymus because usually the lymphoid cells are migrating and persist in the lymphatic tissue, in the thymic tissue, and causes an enlargement or the mass enlargement. Or cerebrospinal fluid evaluation, as we mentioned that because these cells can invade into the central nervous system, and this is how you diagnose. That's very important. First of all, you will see the organ, which organs are affected by this lymphoid infiltration, plus when you are going to treat it, you have to use, for example, chemotherapy in this location, in the testes or in the central nervous system directly, not only in the blood. You have to apply it. This is why you are checking it. Now, immunophenotyping, as we mentioned in the myeloid, it's true for the lymphoid as well. First of all, when somebody does have a sign of acute leukemia, we have to specify whether that's a myeloid or lymphoid. This is usually done by using a CD marker test and using special markers, such as, for example, the myeloid is a CD33 or CD117, as we discussed in a previous seminar. Here we do have, however, some T markers or B markers. You should not learn all of the markers, but at least a few should list. All right. For example, the B-cell marker that can be very useful when we are going to talk about chronic lymphoid leukemia. So CD10, for example, 19, 22, they are very specific marker for the B-cell. Or the T-cell marker such as a CD3 or CD7, that represents the T-cell line. Why is it important to know, let's see, the line? Because the treatment or the prognosis is different one. Now, not only, let's see, the immunophenotyping is very important. Of course, sometimes you do have markers or the cells that has both myeloid and lymphoid, let's see, markers on the surface that usually is less maturated cells, so more aggressive cells. But we have to do some other classifications as well. This classification is good for choosing the right treatment or having some kind of prognostic sign or telling the patient that how long this disease is going to last, what can be the chance to be cured from these diseases. So these are very important ones. We still have two classification systems. Now they are going to apply the WHO classification as we discussed in myeloid disease as well. In the WHO classification that usually we are going to deal with not only the morphology, but we are going to deal with the genetic alteration as well. So the chromosome abnormality or the gene, which gene is affected. This is how they want to specify this kind of leukemias. Now, based on the WHO classification, we do have these lymphoblastic leukemias or lymphomas with recurrent genetic abnormalities. They are going to test which chromosomes are affected. Similarly to the acute myeloid leukemia, the first group, when we do have a very stable chromosome abnormality associated leukemias. However, we still have some not otherwise specified, let's say, leukemias, and this kind of group that is going to be decreased by the age. However, in this group, you have to use the FAB classification. This is why you have to keep the morphology-based classification as well, not only the genetically classified system. And another big group is T lymphoblastic leukemias or lymphomas based on the WHO classification. Now, if you are looking at the FAB classification, that was a very good one because it was very nicely can be categorized based on the morphology of the cells. As you see here in an upper row, these are the typical cells, for example, the L1, L2, or L3 leukemias. Now, the morphology is different one. The L1, the cells are smaller one. Usually the chromatin is a little bit more dense. The cytoplasm is very, very narrow, and nucleoli inside the nucleus almost you cannot see it. In the next stage, when you do have a thicker cytoplasmic area, you do have lighter nucleoli, you do have bigger cells with nucleoli, that's an L2, and when in the number, L1 takes about 75% of the all cases, so this is a majority of the leukemias. The L2 is around 15%, and 1 to 3% is a Burkitt lymphomas. The L3, that's relatively, this is the worst prognostic feature that the patient could have, this L3 Burkitt lymphomas. Now, today's, however, we are going to use this WHO classification. So don't be frightened. You don't need to learn about the cytogenic subgroups. Only you have to know that the WHO classification based on the cytogenetic subtypization of these leukemias. In the future, hopefully, we have only WHO classification, and we are going to forget about the morphological based classification, because those classification doesn't form you a very homogeneous group. So inside one group, L1, for example, some patient responds to the therapy well, some other patient didn't respond at all, some patient can survive for 10 years, can be cured very nicely, another patient basically is dying very soon. This is why they try to make a very precise, let's say, subgroups, and that's based on the WHO classification. As we mentioned before, we do have the first group, this acute lymphoblastic leukemias. The next one, the Burkitt leukemias or lymphomas, and the biphenotypic acute leukemias that usually carries the myeloid and lymphoid cells as well. So this is the WHO classification. And inside the subgroups, we still have this not otherwise specified condition. This is why the FAB is still on. Again, you do not need to know by heart. However, you have to have a clue about how can we give a good prognostic, let's say, suggestion to the patient. These kind of markers, for example, that listed here, can be used to specify the prognosis of this patient. For example, if somebody does have a normal karyotype and high haploidity, mostly trisomia of the chromosome 4, 10, 17, or the deletion of the 9, these are the better prognostic, let's say, leukemias. Poor prognosis when we do have some translocations, for example, or the age is higher one, or the white blood cell count is higher one, or that no remission occurs by the treatment, so the patient does not respond to the treatment. These are bad prognostic features. And if you remember that very poor prognosis when the patient carries the Philadelphia chromosome, that's enough. All right, so please remember, Philadelphia chromosome is not only a marker for CML, but Philadelphia chromosome can occur in acute lymphoid leukemia. In that case, that's very bad because the prognosis is very poor. Let's look at this case study. That's different what we do have as a case study for the final one. This only is going to show you how the patient is going to be evaluated. A 46-year-old female patient with known hypertension and IBD. 3 weeks earlier, she had retrosternal pain radiating to the back, accompanied with mild fever and dyspnea. The general practitioner's diagnosis was airway infection and antibiotic was prescribed. Since her symptoms deteriorated, so it's not proved, the chest X-ray was taken, which showed infiltration on the right side. Her condition didn't improve even after switching antibiotic. Therefore, laboratory studies were performed where significant blood count alterations were found, and the patient was sent to the hematology department. So if somebody does have repeated infection or banal viral infection causes pneumonia, for example, you have to let's see, check the patient blood using only the blood counter, the CBC. And if you do see some atypical cells, immediately go to the hematologist, especially when you're looking at the age young one, 2 to 5, or around 50. These are the two peak for these leukemias. Physical examination, as you see here, pale skin showing anemia, hematomas through the body, petechiae, pale conjunctival mucous membrane, pathologic lymph node not palpable. So we do have a sign of decreased red blood cell count or a decreased platelet count. These are the two that we do have. The patient has resting dyspnea, crackles at the base of the lung and the right side do sound by percussion, soft and palpable abdomen and large spleen. And large spleen could mean a lot, especially when we are talking about leukemias. Which leukemia accompanied with a very huge spleen? So far what we learned. You are almost right, chronic mild leukemia. In chronic mild leukemia, the splenomegaly could be tremendous. But in acute lymphoid one or chronic lymphoid one, we still have splenomegaly. Now, the pulse of the patient was 120, so tachycardia. Why? Possibly due to hypoxia and due to anemia. Okay, and her temperature was 37.4, so subfever. Chest X-ray bilateral pleural effusion, significant enlargement, and large mediastinum was detected. See here the lab results. White blood cell count tremendously increased, about 200,000 per microliter. So it's a very huge amount of white blood cell. That can cause leukostasis. So if you are not curing this patient, that can cause ischemia in the periphery. Red blood cell count decreased, almost half than a normal value. Hemoglobin 71, less than 120 for sure is anemia. Hematocrit almost half what you should have. Platelet count 19 giga per liter. Now this is why this patient has petechia, because how much is the platelet count that preventing the spontaneous bleeding? 50 giga per liter or 50,000 per microliter, yes. So she had lower one, that 50. This is why the petechias and easy bruising could be seen. LDH, look at the LDH activity. Normally around 150. Now we do have 2,000, almost 3,000 units per liter. So it's very highly increased. They looked at the histology and they did find in the peripheral blood at least 80% of the moderate cell-rich smear is atypical, immature lymphoid population with cells slightly larger than small lymphocyte. The cells have usually round or in some case fragmented nucleoli, and cytoplasm is narrow, basophilic, and most cell is slightly vacuolite. Flow cytometry, when they looked at the CD markers, the T cell markers were positive, and as you see here, about 85% of the peripheral blood lymphoid cell showed the T cell origin. And cytogenic studies, no chromosome abnormality was found, and diagnosed the precursor T cell lymphoblastic leukemia without cytogenic abnormalities. Now, the treatment of lymphoid leukemias. Mostly they are going to apply combination chemotherapy. They are going to combine different chemotherapy agents, or biological treatment should be used as well. Transfusion of the red blood cells and the platelet to replace the red blood cells and the platelet is important. So these are the maintenance therapy of the patients. And by the cytotoxic therapy, the chemotherapy is going to reduce the blast cells, and this is how the normal cells can later on produce. Bone marrow transplantation relatively can be applied if the patient responded to the therapy and in a relapse phase, only in that case. But the side effect of the bone transplantation is very, very high, because when you destroy the all cells or white blood cells, relatively the patient is very sensitive to any kind of infection. This is why you have to insulate the patient and keep in a sterile environment. And after, when you replace the stem cells, you have to wait when the stem cells is going to home and start to proliferate, start to differentiate. It takes several weeks before the patient can recover from this situation. And this is why the elderly one usually cannot tolerate this kind of treatment. Now, the treatment or the chemotherapy for acute lymphoid leukemia a little bit different from the myeloid one. At the beginning is the same. So when we do have the induction of remission, so we want to reduce the blast cell count, we want to suppress the growth of the blast cells. And after, they are going to use this intensification and consolidation therapy. And as you see here, sometimes they have to apply the therapy in the central nervous system and in the testes as well. Because in those areas, these lymphoid cells can hide and can re-invade or reseed into the bone marrow, and that can cause an early, let's say, progression of the diseases. And if the patient relatively has a very low number of the blast cells, the maintenance therapy should be used. This was the acute leukemias. That was very similar in some cases, for example, the treatment other with the myeloid leukemia and the classification as well. So the goal is the same, making a very homogeneous group based on the genetic evaluation, and after we can treat the patient. Now, similarly to the CML, we do have CLL as well. The connection between, or the similarity between the chronic lymphoid and chronic myeloid, that this disease has a slow, let's say, progression. The patient can live years without having any treatment. Now, the advantage of, let's say, CML, that CML relatively, now we know the pathomechanism, we can cure very nicely. We can use the tyrosine kinase inhibitor when we do have this BCR-ABL translocation and this fusion gene made tyrosine kinase, and the inhibitor works perfectly. The patient should take this drug and relatively lives the long, long time. In chronic lymphoid leukemia, the treatment is not as simple. This CLL, I would say that so far we believe that this CLL is an incurable disease. However, there are new drugs, new treatment that is going to affect directly the affecting the etiologic key factors, for example, as we see later on, the BCL2 genes. But the good thing in the CLL that usually a huge amount of patients does not need any therapy. They can live as long as you wish without having therapy. Another good thing, this CLL occurs in late age. This is why usually they are going to die earlier from different diseases and not from CLL. Now let's see. CLL is a very common type of acute leukemia. It takes about 1/4 of the all leukemia. So relatively the incidence is very high. As you see here, doesn't affect children, the disease of the old people. The incidence is between 60 and 80%, age of 60 and 80. The tumor cells appear to be a relatively mature B cells. The T cell accumulate in the blood or in the marrow, liver, spleen, and the lymphatic nodes. And the results of the increased production or the prolonged lifespan with the impaired apoptosis, that's very, very important. So they are going to proliferate and they are not going to die because the shutdown mechanisms are altered. This is why I said the BCL2 apoptotic signal is altered. There is another type of lymphomas that is small lymphocytic lymphoma is identical with the CLL, except that's a tissue localized version of the CLL, as you learn in pathology. Now, clinical presentation. As we mentioned that this disease occurs in late age. The male is more common than in female, these diseases, and about more than 80% of the cases discovered by the routine blood test. So this disease is diagnosed before the clinical symptoms occur. Only the patient goes for checking, regular checkup for every year, for example, renewing the driver's license or any kind of test, and he diagnosed that the lymphocyte count, the absolute lymphocyte count, is increased. It's higher than 5 giga per liter. That's it. That's the diagnosis. Nothing else. Later on, when the organ manifestation starting, for example, enlarged cervical or axillary inguinal lymphoid nodes can be detected in very frequent clinical sign. And that can be discrete one or can be symmetric one. And anemia and thrombocytopenia usually occurs in the late stage only, not at the beginning. Very similarly to the splenomegaly and the hepatomegaly as well. The patient who has this B cell abnormality, they do have immunosuppression. They do have some monoclonal antibodies to develop because these B cells carry some immunoglobulin on the surface, mostly IgM in the surface. And that is relatively, is going to alter the polyclonal immunoglobulin synthesis. So the patient does have a problem with the humoral and the cellular immune system. So at the beginning, mostly the patient suffering of the bacterial infection. Later on, viral and fungal infection can occur. So in the later stage, for example, herpes zoster infection can be seen in the patient very commonly. This is how it looks like. Symmetric bilateral cervical lymphadenopathy can be seen here, or the typical sign of herpes zoster infection in an immune suppressed people, for example, who has this CLL. Now, what the pathomechanism for this or physiology for the CLL? Basically, an early step of the B cell affected, mostly 95% the B cells are affected. We do have a genetic stage that involves the apoptotic signal. As we mentioned, then the anti-apoptotic protein is BCL2 level is increases, and that's the new treatment when they are going to apply anti-BCL2, let's see, treatment for this patient. And the gradually, slowly accumulating lymphocyte count in the periphery or in the bone marrow occurs. Now, this is going to be altered by the progression of the disease. Some stage can be very fast, can deteriorate the patient's life very easily, or in some other case, this duplication rate or accumulation takes ages when they come. Now, the cytogenic abnormalities that can be detected about 50% of the cases. If you remember that this chromosome 13 and 14, that's the most common type of genetic alteration, and several oncogenes can be affected when we do have the CLLs. How do we make the diagnosis? Very simple. let's diagnose in a peripheral smear an absolute increase of the lymphocyte count. That's it. Later on in the bone marrow, we do have about more than 30% of the lymphocyte. Normally, we do have less than 10% of the lymphocytes in the bone marrow. And these lymphocytes are not normal lymphocytes, all right? So basically, about 5% of the lymphocytes are atypical lymphocytes. Again, how do we diagnose? Very easily. Not only the number of the cells effect is important, but the type of the cells. This is why they do the cytogenic, let's see, markers, so flow cytometric evaluation, searching for CD markers. Now, which are these CD markers? They are very important ones. CD5 is an early B marker or the T marker. This marker is lost normally during the maturation steps. However, this clone is going to carry the CD5 together with the matured B cell markers, such as the CD19, CD20, 23, and 52. Very importantly. So we are going to measure the co-expression of the CD markers. CD5 always is involved in this story. And after the immunoglobulin gene studies, for example, is checked, or other lab parameters should be detected. For example, autoimmune hemolysis is a very common one in these patients. So sometimes a hemolysis or a anemia, the first sign of autoimmune hemolytic anemia, can direct you to the CLL. Positive cum text is about 30% of the cases, and the hypogammaglobulinemia seen in the patient about 50%. And they do have the monoclonal peak as well. So when we are going to talk about paraproteinemia, such as the multiple myeloma, you have to exclude CLL because CLL can have monoclonal gammopathy, can have a narrow M peak in the serum electrophoresis. Look at this peripheral smear. Very nicely, you can see lymphocytes, almost all of them close to the maturated lymphocyte, and atypical cells. These are these eosinophilic patches. This is called as smudge cell. These smudge cell, or Grünprägt bodies, that if you like the name. These Grünprägt bodies is a leftover of the nucleus of the blast cells, because these cells are very fragile one. And when you make the smear, you are damaging the cells and you are smashing, let's see, the nuclear content, and that gives you this smash cell-like feature. This is the flow cytometric analysis. You can read out, for example, they stained with the CD5 and CD19, and you do see both, so there's a co-expression, and all of them is showing that these patients, for example, who had this kind of chronic lymphoid leukemia, they do have the CD5, CD19, 20, 23, and 79B, let's see, co-expression, and the lambda light chain, so the monoclonality can be detected. This is how they are going to detect or diagnose CLL. Not enough to diagnose CLL, but before you start treating the patient, you have to give a clue about, let's see, the prognosis of this patient, whether it's a good or bad. Mostly is good. Now, this table is going to summarize those markers that should be checked, or they are going to check, to inform the patient about the status of these diseases. For example, female is good. If the doubling time is slow, what does it mean slow? If the duplication of the lymphocyte count takes longer than 1 year, 12 months, that's good. However, if it's less, relatively, they are going to grow and going to multiply the cells faster. When we do have the most common type of genetic mutation, as I mentioned, that the 13q14, that's a good prognostic feature. If you do have the deletion of 17, that's a bad one. Another thing, look at, for example, the heavy chain genes on the surface of, let's say, the B lymphocyte. If it's hypermutated, it's good one, because this is normally happening in the B cells. When they are going to have this hypermutation, when they are going to relatively differentiate or grow, they have to have a polyclonality. If it's hypermutated, higher chance to have polyclonal immunoglobulin. If it's not hypermutated, very high chance to have a monoclonality, and they are going to cause an immune deficiency because their monoclonal immunoglobulin cannot defend the body. ZAP kinase, that's a kinase, that's a zeta chain associated protein kinase that they are checking it to see as a prognostic key. If the activity is low, very low, well, less than 20%, that's good. If it's high, that's a bad prognostic feature. LDH very similarly. LDH showing, let's see, the metabolic rate, how is effective. If it's high, that's bad. If it's low, it's all right. CD38, again, they are checking it. The positivity is bad. If the patient does not have CD38 positivity, that's a good one. So they do have very high chance to live for a long life. The staging system is going to help us again to figure out the treatment or to have some kind of sign for prognosis. There are two staging systems, the pure staging system, the Ray and the Binet staging system. We do have an international staging system that's a modified Ray staging system. Relatively, this modified system is only give you a prognostic, a survival feature, so they can tell the patient how long they are going to live. In the first stage, stage 0, this is a low risk, the patient lives more than 10 years, roughly around 13 or 14 years without treatment. And the intermediate stage lives about 8 years, and the high risk about 6.5 years. Now, very good thing to see this CLL. When the patient diagnosed with CLL, in most cases, they don't need any treatment, not at all. So patient comes to the clinic, you give the diagnosis, you have CLL. The patient is frightened completely because you are saying leukemia. All right, now what could be the treatment? Nothing. But I have to have something. I have leukemia. No. The treatment is not needed unless we do have bone marrow or organomegaly. When they do have some clinical symptoms due to this organ effect. Because the treatment has much more side effect than without treatment. This is why they are waiting. Now, a lot of cases, the patient doesn't need treatment. For example, if this leukemia develops in age of 80, for example, those patients already had some other diseases, for example, cardiovascular diseases or other tumors or other things. So, and the patient usually die with the other diseases, not from CLL, not due to CLL. And especially if you start treating, the patient cannot tolerate the treatment. That's another problem. However, in an advanced stage, yes, you have to treat the patient. Now, what treatment they are using, if they need it, they're using a combination, for example, a chemotherapy and with a biological treatment. They're using the anti-CD20, this is rituximab, together with the cyclophosphamide and steroids. And this is how they can control the growth of the lymphocytes, and the organomegaly usually is suppressed, so they are going to reduce the swelling in most cases. Now, this is the course that I mentioned, that in many patients in stage 0 or 1 without favorable prognostic markers never need therapy, and they can survive without having any kind of treatment. And with those that need treatment, only they are going to give when the patient has marrow infiltration that's represented with anemia or thrombocytopenia or organ manifestation, sleep, and for example, the spleen, splenomegaly, or liver enlargement. In some patients, they can suffer of a transformation of these cells, and that's called the Richter's transformation. And these cells, the transformed cells, basically they be resistant to any kind of therapy. So it's a very bad prognostic feature if it's happening. Now, these case studies that we do have for CLL, that's a 62-year-old female patient with appendectomy, hysterectomy, and hypertension in her anamnesis. Recently, she observed lymph node enlargement in the neck, groin, and the armpit. Okay. Lab results, generalized lymph node enlargement which are soft and not fixed, spleen 1 inch below the rib cage, and as you see the blood count analysis, white blood cell is increased, lymphocyte count increased, the absolute number is 8.6 giga per liter, so it's higher than 5 giga per liter. Everything else is normal. So this patient does not have any kind of bone marrow involvement. Okay, biopsies were taken from enlarged lymph nodes, flow cytometry performed from peripheral blood, and 50% of lymphoid cells are kappa monoclonal B cells co-expressed with CD19, CD5, and CD23. So that's identical for the chronic lymphoid leukemias. And the B cell shows high CD38 expression as well. Is it good or bad? That's a bad prognostic feature. This at the beginning, so the patient does not need any therapy, but this patient needs a close checkup. So checking how the lymphocyte count is going to change, how the organs are infiltrated, they have to do it. Now, because this patient later on, when they develop, let's say, organ manifestation, they treat, especially with a bad prognostic feature. This is a combination therapy that I mentioned, which can be used for this patient to control the growth of the lymphoid.